Welcome to the Deep Dive. Today we're tackling a really challenging area in medicine, muscle lesions. Basically conditions that cause muscle weakness, fatigue, even atrophy, affecting the whole skeletal muscle system. Our sources cover a huge range, from rare genetic things to common drug side effects. So our mission today is efficiency. You want to shortcut that diagnostic path, really cut through the noise to find the key clinical clues that help tell these complex conditions apart, give you that faster route to clarity.
Yeah, and that clarity is so important because, wow, the possibilities are vast. We can sort of make two big buckets right off of that, which helps. You've got the hereditary conditions, things like periodic paralysis, muscular dystrophies like Becker's, myotonic dystrophy.
Okay.
And then on the other side, the non-hereditary or acquired causes. So that's like statin side effects, inflammatory conditions, or even things linked to, say, being in the ICU.
Okay, right. Let's break that down. Imagine a patient comes in, profound weakness. What's the absolute first thing we do before we even think about labels?
Well, it's always back to basics. The ABCDE assessment: airway, breathing, circulation. Is the patient stable? Because if they're acutely unstable, if their breathing is compromised, everything else stops.
Diagnostics out the window for a moment.
Exactly. It's all about stabilization. That could mean rapid intervention, maybe even intubation, mechanical ventilation, especially if those respiratory muscles are failing. You secure the patient first. Diagnosis comes second.
Makes sense. Okay, so let's focus on the stable patient then, the one where we can take a proper history, do a good exam. What are the main symptoms that really shout muscle lesion?
History-wise, it's almost always symmetric weakness, both sides, usually in the limbs. But the real red flags, the things you really worry about, are difficulty swallowing, dysphagia, or shortness of breath. That signals bulbar or respiratory muscle involvement.
High risk.
Very high risk. And then on the physical exam, if it's been going on a while, you might see obvious muscle wasting, atrophy. And look for that characteristic waddling gait. That tells you the hip and pelvic muscles are quite weak.
Okay, that paints a clear picture of the motor side. But what's the single most crucial thing on exam that helps us rule out other stuff, like, say, nerve problems?
This is the key differentiator, the absolute aha moment. Because these lesions affect only the muscles, the skeletal muscle system itself.
Oh.
The sensory exam will be completely normal. No numbness, no tingling, nothing like that. That's sensory sparing. That points you directly towards a primary muscle problem, a myopathy.
Okay, that's huge.
It really is. Muscle tone and reflexes, they can be variable, sometimes normal, sometimes decreased, but that normal sensory exam, that's your high-yield clue.
Got it, yeah. So that normal sensory exam just changes everything. Now, we started with stability. What about the context?
Sure.
When does the patient's environment, like being critically ill, point towards a specific myopathy?
Yeah, that's a big one. If you're dealing with a patient who is currently in the ICU or maybe just recently discharged from one, you have to think about critical illness myopathy, or CIM. It's very context dependent. You often see it with things like sepsis, multi-organ failure, or really importantly, after high doses of glucocorticoids, steroids, especially if they were used alongside paralytics.
Okay, and how do we keep that separate from something related, like critical illness polyneuropathy? People sometimes mix those up.
Right, good question. It goes straight back to that sensory exam clue. CIM is pure muscle myopathy, so normal sensory exam.
Okay.
Polyneuropathy, though, involves the peripheral nerves. So with that, you'd expect to see both muscle weakness and sensory deficits, numbness, tingling, altered sensation. That distinction is vital in the ICU setting.
Perfect. Okay, let's shift gears. Move away from the ICU. Now we're looking at patients not critically ill, but they do have a family history suggesting something genetic. What's the first thing we assess then?
Here, the tempo of the symptoms becomes really important. Are the symptoms episodic? Do they come and go dramatically? Or are they persistent, maybe slowly getting worse over time?
All right, let's take episodic first. What falls into that category?
If it's clearly episodic, like the patient is fine 1 minute, then suddenly weak or paralyzed the next, we're diving into the periodic paralyses. These are fascinating conditions, usually autosomal dominant, all stemming from problems with ion channels in the muscle cell membrane.
And the triggers for these episodes sound incredibly specific, almost bizarre sometimes. What are the main types?
They are very specific. Let's start with hypokalemic periodic paralysis. Hypo, meaning low potassium. Here, the weak episodes can last quite a while, hours, sometimes even days.
Wow.
And the triggers, often metabolic things, big carbohydrate meals, drinking alcohol, and this is a classic one, resting after strenuous exercise. Lab-wise, during an attack, their serum potassium is low, genetically. Look for mutations in SAC-NA1S, the calcium channel gene, or sometimes SCN4A, a sodium channel gene.
Okay, so low potassium, triggered by carbs or rest after exercise. What about the flip side? Hyperkalemic periodic paralysis.
Almost the mirror image, clinically speaking. Hyperkalemics is so potentially high potassium. The episodes here are usually much shorter, typically just hours.
Okay.
Triggers include potassium-rich foods, fasting, getting cold, or, again, resting after exercise. But a key symptom here is often baseline muscle stiffness. They call it myotonia, because the muscles have trouble relaxing properly.
Interesting.
Labs might show normal or high potassium during an attack, and the gene is almost always that sodium channel 1, SCN4A.
Got it. So episodic weakness covered. Now, what if the weakness isn't episodic? What if it's persistent, progressive, getting worse over time, and we still have that family history clue?
Right. If it's persistent and progressive and there's a family link, we have to consider the muscular dystrophies. A key one to know is Becker muscular dystrophy, or BMD.
Becker's.
Okay. Becker's is X-linked recessive, so it predominantly affects biological males. Unlike the more severe Duchenne form, onset is usually later, maybe adolescence or early adulthood. Clinically, patients report progressive trouble with things like walking, running, climbing stairs. And the exam, very informative. Look for calf pseudohypertrophy. The calves look big, maybe even muscular at first, but it's actually compensatory growth followed by infiltration with fat and connective tissue, so they feel firm or rubbery.
Right.
You'll also see proximal weakness shoulders, hips often leading to that lumbar lordosis, the sway back posture, and the waddling gait we mentioned.
Now, Becker's involves a partially functional dystrophin protein, whereas Duchenne has virtually none, leading to that earlier, more severe presentation. Does the cardiac risk differ much? Is cardiomyopathy still a major concern in Becker's?
Oh, absolutely. That's a critical point. Even though the skeletal muscle disease might seem mild or start later in Becker's compared to Duchenne's, the risk of developing cardiomyopathy, heart muscle disease, is still very significant. So cardiac screening is absolutely essential for patients with Becker's. Don't underestimate the heart risk just because the muscle symptoms are later onset.
A really important takeaway. Okay, let's tackle another major genetic player. Myotonic dystrophy type 1. What's the classic thing a patient might complain about that makes you think of this?
The absolute hallmark is myotonia, specifically difficulty releasing a grip. They'll say, I shake someone's hand and I can't let go quickly, or they struggle with doorknobs. Fine motor tasks too, fastening buttons, opening jars, and importantly, these symptoms often get much worse in the cold. But it's not just muscles. You have to look for the non-motor signs too, things like cognitive issues, early cataracts, heart rhythm problems, arrhythmias causing palpitations maybe. On exam, look for a characteristic pattern of facial wasting temples, jaw muscles plus drooping eyelids, cytosis, and maybe slurred speech, dysarthria.
And aren't there those two classic physical exam maneuvers for myotonia?
Yes. The dynamic duo for diagnosis at the bedside. First, grip myotonia. Have them squeeze your fingers hard, then watch how slowly they relax their grip. Second, percussion myotonia. You gently tap the thenar eminence, the base of the thumb, and you'll see the thumb muscle contract and stay contracted for a bit.
Fascinating. And then there's that really unique diagnostic clue you can actually hear.
That's right, it's auditory. On EMG, electromyography, the electrical myotonia creates this really distinct sound as the needle picks up spontaneous muscle fiber discharges. It sounds like a dive bomber airplane.
Oh.
That sound is basically pathognomonic for type 1, which we now know is caused by a CTG repeat expansion in the DMPK gene. Just briefly, there is a myotonic dystrophy type 2, different gene, CMBP, usually later onset, affects proximal muscles more, but type 1 is the classic form with that grip myotonia and dive bomber sound.
Excellent overview. Okay, we've covered the genetic side. Let's pivot now to the acquired causes patients presenting with weakness but no family history. Where do we usually start the investigation here, pattern-wise?
Typically, we look at the pattern of weakness again. Often, acquired myopathies present with proximal weakness, especially in the upper limbs. So the patient might say they have trouble lifting their arms overhead, like washing their hair or reaching for things on a high shelf.
Makes sense. So with that proximal weakness, no family history, what's the first potential cause to rule out?
The first thing you absolutely have to ask about is statin use. Statins are incredibly common drugs, often started after a heart attack or stroke. If someone develops muscle weakness, maybe muscle pain too, relatively soon after starting a statin, then statin-induced myopathy is very high on the list.
And the good news is, this usually gets better.
Usually, yes. That's the key outcome.
Hmm.
Typically, the symptoms resolve, often completely, within a few weeks of stopping the statin.
Okay.
But, and this is important, you can't dismiss it. In severe cases, it can cause significant muscle breakdown, rhabdomyolysis, which can lead to acute kidney failure. So while often reversible, it needs to be taken seriously.
Good warning. Okay, so if statins are ruled out, we move towards the idiopathic inflammatory myopathies. And you mentioned earlier, the key differentiator here often comes down to the skin.
Exactly. The skin exam becomes crucial. So if you have a patient, proximal weakness, maybe elevated muscle enzymes like CK,
Yeah.
but their skin exam is totally normal, no rashes,
Yeah.
then we tend to call it polymyositis, PM. If you were to biopsy the muscle, you typically see inflammation within the muscle bundles, what we call endomyosial inflammation. However, if the skin is involved, then the diagnosis shifts to dermatomyositis, DM. And this relies on spotting some very specific, quite memorable skin signs.
Like what? What are the classic ones?
Well, the most famous is probably the heliotrope rash. That's a reddish-purple discoloration, sometimes with swelling right on the eyelids. You might also see red patches across the shoulders and upper back, like a shawl. That's the shawl sign. Or a similar rash in a V shape on the front of the neck and chest, the V sign.
Okay, I can picture those. What about the hands?
Ah, the hands are key. Look for Gautron papules. These are raised, reddish, purplish bumps right over the knuckles, the bony parts. If you see flat red patches over the elbows or knees, that's called the Gautron sign. And finally, check the hands for roughness, cracking, thickened skin along the sides and tips of the fingers. It's called mechanic's hands.
Got it. Heliotrope, Shawl V, Gautron's, mechanics hands. And the biopsy is different in DM too.
Yes. In dermatomyositis, the inflammation tends to be more around the edges of the muscle bundles. In the connective tissue, what we call parafascicular and paramecial inflammation, it targets a different area than polymyositis.
And there's a really important clinical association with both PM and DM we need to remember, right? Raises the stakes quite a bit.
Absolutely. Both conditions, but especially dermatomyositis, carry an increased risk of underlying cancer, particularly things like non-Hodgkin lymphoma, but also various solid tumors, ovarian, lung, pancreatic, stomach. Finding PM or DM means you need to think about and often screen for an underlying malignancy.
Wow, okay. That's critical context. Now, we've mostly talked about proximal weakness. What if the pattern is different? What if it's mainly distal weakness, especially in the arms or hands?
That specific pattern points us towards a different entity entirely, inclusion body myositis, or IBM. This typically affects older adults, usually over 50. It's characterized by a very slow, insidious onset of progressive weakness. And notably, it's often painless, unlike the inflammatory myopathies, which can be quite painful. But the real key is the distribution. IBM has this peculiar preference for attacking the finger flexors and the quadriceps. So patients complain specifically about weakening grip strength, difficulty with buttons, opening jars, things needing fine finger control, and maybe tripping or difficulty getting up from a chair due to quad weakness.
And the diagnostic confirmation. Biopsy again.
Biopsy is key for IBM. You're looking for very specific microscopic findings. Muscle fibers containing what are called rimmed vacuoles, basically little empty spaces with distinct borders, and sometimes protein aggregates or inclusions within the cells.
Incredible. What a journey from the ICU through these really specific genetic channel problems, dystrophies with unique signs, drug side effects, and then these inflammatory conditions differentiated by skin signs or even finger weakness.
It really covers a huge spectrum, doesn't it? But you can see how getting a handle on those key patterns, the tempo, the distribution of weakness, the sensory exam, specific triggers, skin findings, those unique exam signs like myotonia really allows you to navigate this complex field.
Yeah, it really boils down to pattern recognition. Knowing the difference between, say, that dive bomber sound on EMG and seeing rimmed vacuoles on a biopsy. It lets you zero in so much faster. It's a powerful shortcut through potentially overwhelming differential. So hopefully this deep dive helps you, our listener, feel more confident in recognizing these patterns. Thank you for joining us.
And maybe one final thought to leave you with. We mentioned that polymyositis and dermatomyositis are linked to cancers like lymphoma. It raises a fascinating biological question. How exactly does the immune system attacking the muscle tissue relate to, or perhaps even trigger, an underlying malignancy? That interplay between autoimmunity and cancer risk in these conditions, that's definitely something worth pondering further.